Hello, everyone, and welcome to today's webinar, Let's Make Time, Understanding Diabetes Complications. I'm Rachel Reeve, Executive Director of Research and Science at Diabetes Canada. Before we begin, I want to take a moment to acknowledge the importance of the lands which we each call home. I'm coming to you from the traditional territory of the Haudenosaunee and Anishinaabe peoples. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people who call this land home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of the local Indigenous peoples and their cultures. A few small housekeeping items before I introduce you to our panelists. This meeting will be recorded. We will begin by getting to know our incredible panel who all come today from diverse and interesting backgrounds. After that, everything will be live and interactive. Both the Q&A and chat functions are open in Zoom, so please enter any questions you have and I'll ask them to our panelists on your behalf. The chat is visible to all participants, and if remaining anonymous is important to you, the Q&A function located at the bottom of your screen is only visible to the panelists. If you're joining us by phone through the toll-free number, you can submit your questions by email to research@diabetes.ca, and we will try to get through as many as time allows. It is with great pleasure that I introduce you to our exceptional panel. We will be hearing from two Diabetes Canada funded researchers, Dr. Kelvin Key and Dr. Kristen Clemens, as well as a diabetes advocate, lived experience research partner, and public speaker, Sasha Delorme. Each of these remarkable individuals brings forth their own unique journey and insights, and they all share a commitment to better understanding the complexities of diabetes. We extend our deepest gratitude to our esteemed panelists for joining us today, and to our audience, we sincerely appreciate your presence. It is through the collective efforts of dedicated individuals and partners like yourselves that Diabetes Canada is able to advance its mission. Your support enables us to fund vital research initiatives, offer invaluable resources to our community, and persist in our unwavering commitment to end diabetes. So thank you for your support. To start us off, here is Dr. Key.
So hi everyone, my name is Calvin Key and I'm very happy to be here today to talk about some of my work that's funded by Diabetes Canada, focus on the topic of young onset type 2 diabetes, and I'm going to share a little bit about what I'm doing in this space today. I am an assistant professor and a clinician scientist at the University of Toronto and at Toronto General Hospital at University Health Network in downtown Toronto. So some of you might be thinking, what exactly is young onset type 2 diabetes if you've never heard of it before? So there are different forms of type 2 diabetes. So we're not talking about type 1, we are talking about type 2, but we are classifying people according to the age at which they are diagnosed. So people who were diagnosed before the age of 40, they are considered to have young onset type 2 diabetes, whereas people diagnosed at age 40 or later can be called later onset or usual onset type 2 diabetes, which is more of the typical form that most people are used to thinking about. Now, what's so special about young onset type 2 diabetes? Well, it's actually becoming increasingly common. If we were to go back 30, 40 years ago, there were not very many young people under the age of 40 with type 2 diabetes. However, just in the past 3 decades, the occurrence of young onset type 2 diabetes has increased by over 100%, as you can see from this graph, from the recent work that we've done in this area. And actually, if you look at young people below the age of 40, below the age of 30 with diabetes, you'll see that the most common type of diabetes they have is type 2 and not type 1, contrary to what people's preconceptions might be. So it's very common now, and it's becoming increasingly common. Why is it important? One of the most important studies that we have looking at this topic is called the Today study. And this study specifically looked at youth with young onset type 2 diabetes age 14, 15, approximately when they were diagnosed. And they followed up these people over 10 to 15 years. And what they saw, as is shown by this graph on the y-axis, is the rate of having a complication. So that's something, a consequence of diabetes, such as kidney disease, eye disease, or nerve damage. And the higher this line goes, the more people have had a complication as a percentage. And on the x-axis is the follow-up time, so the number of years that have occurred since diagnosis. And you can see that by around 9 to 10 years, over 50% of people already have some complication of diabetes, young onset type 2 diabetes. And these are people in their 20s. So this is extremely high, much higher than what we see with older adults with type 2 diabetes. And what types of complications that are having? So some people have nerve damage, some people have kidney damage, some people have retinal damage, some people have a combination of 2 or even 3 of these complications. And so it's a very, very big problem. It's causing these complications that people are going to be living with decades, and it's going to continue to progress and get worse over time. And so this is a major reason why people with young onset type 2 come to the hospital so often. This graph shows on the y-axis the rate of coming to the hospital, and on the x-axis is the age of people coming to the hospital. And the white bars are people with young onset type 2. And so you can see these bars are very high, and they're highest across all ages of people. Of course, when you get older, you come to the hospital more, but even at young ages, these people are coming to the hospital. The general population is the dark green bars. They have the shortest heights of these bars, meaning that they're not coming to the hospital as much as people with diabetes. And people with later onset diabetes, they come to the hospital at a rate that's somewhere in between people without diabetes and young onset type 2 diabetes. So they're coming to the hospital a lot for these problems that are occurring. And what does that lead to? Well, it's very sobering to look at some of these statistics that were actually measured in Swedish countries, which showed that the earlier that somebody is diagnosed with diabetes, the more life they're expected to lose. And so somebody who's diagnosed at around age 20 can expect that they might die about 12 to 15 years earlier than somebody who doesn't have diabetes at the age of 20, who might be expected to live up to age 88, whereas somebody who's diagnosed at that age might live to 75 or 76. And this gap is especially wide between the red dots and the blue dots among people who were diagnosed earlier in life. And so this is a really major problem. We don't know how to deal with this yet. And we were still trying to understand why some people with young onset type 2 have such high risks of complications. And, in order to understand why, we kind of have to take a step back and, think about type 2 diabetes in general. And so type 2 diabetes, as many of you well know, requires management of risk factors, things such as blood sugar, cholesterol, blood pressure, etc. And the reason why these risk factors need to be managed is that higher levels lead to a higher risk of these complications. Higher levels over many years will lead to an even higher risk of complications. So it's very important to manage these risk factors to target levels. And so Diabetes Canada has set targets for how blood sugar and blood cholesterol need to be managed. And so this is the work that we're doing in our lab right now to understand how we can better manage young onset type 2 diabetes with regard to these risk factors in order to avoid these complications. And so it's really important to understand not only what the levels of these risk factors are, but also how the levels change over time, because they're so young when they're diagnosed that they live for decades and decades with type 2 diabetes. and we need to understand how that changes over time. And so this is a research that is filling a very important gap because prior research has excluded people with young onset type 2 diabetes. We've shown that in the major studies that have looked at how to manage type 2 diabetes, young adults were basically excluded. Whereas our research includes adults across all ages, so we can compare what the differences are and really understand what is occurring in people with young onset type 2 diabetes. And so this is some of our most recent work that looks at blood sugar levels over decades. And if you just consider that the average age of diagnosis of type 2 diabetes is close to age 50 in Canada, somebody diagnosed at age 50 might have a blood sugar level here that is shown in the blue line. And so on the x-axis is their age over time, and y-axis is the level of the blood sugar. So you can see that it's the highest at the time that they're diagnosed. They take some medication, it goes down, and then it gradually creeps up and settles down at about this level. And this is what it looks like for somebody who's age 50, and we project until they're age 80, 30 years with type 2 diabetes. This is the type of level they'll be at. Diabetes Canada actually recommends for most people that the level should be close to 7%, although that does vary over time. But you can see that on average, people are not meeting their blood sugar targets. This is for average people diagnosed at around age 50. Now, if we look over the lifespan, we'll see that as people are diagnosed at older ages, their blood sugar level doesn't actually start out as high at the time of diagnosis. It actually seems to be lower than people who are diagnosed in their 50s, whereas by age 60 and age 70, their levels seem to be better at the time that they're diagnosed. On the flip side, if we look at people who are diagnosed before the age of 50, in their 40s, their 30s, their 20s, we see that the blood sugar levels are much, much higher at the time of diagnosis, and they stay persistently high over decades, much, much higher than people who are age 50s or 60 or 70 when they're diagnosed, and far, far above the recommended target levels of 7% or less, which would typically apply to young adults with type 2 diabetes. So we're really far from meeting the target levels that we need in order to avoid complications. Now, I said that blood sugar was important, but cholesterol is also important as well alongside blood sugar. And what do we see about the cholesterol levels? Well, this is a similar graph of cholesterol levels across different ages. And we see again that people who are diagnosed on average at about age 50, they have high cholesterols at the time of diagnosis, but the levels go down over time. And people who are diagnosed at older ages, they're gradually seem to be managed better. And these levels of cholesterol seem to eventually hit the targets that Diabetes Canada actually recommends. It can take many years for people who are diagnosed at different ages, but they are headed in the right direction. But what about people who are diagnosed at younger ages? Well, we can see that for young onset type 2 diabetes, the cholesterol levels are far, far above the level that they, are recommended to be by Diabetes Canada, and especially for people diagnosed in their 20s and 30s, they're not close to hitting the target levels that are needed to avoid complications. And so this is what our work has revealed, that there's a lot of work to be done to understand really how to prevent this from happening and to manage it better. And so our ongoing research is trying to help us develop better strategies for young onset type 2 diabetes management. We know it's increasing. We know the complication risks are very high. And now we know that blood sugar and cholesterol levels are persistently above targets among young adults with type 2 diabetes. What we're still working on is understanding the impact of these high levels, precisely the impact on things like heart disease, stroke, kidney disease, and also developing strategies on how we can better manage these levels in terms of better treatment strategies and better guidelines so that care providers and patients can have a better understanding of how to hopefully prevent complications in the future. I want to thank you for your generous support of Diabetes Canada and acknowledge the support that I'm so grateful to receive in order to fund this work. Thank you.
Good evening, everyone, and thanks so much for the opportunity to share our research with you. While ultimately we hope to end diabetes and its complications, many Canadians still do live with long-standing diabetes as well as structural consequences. So this evening I'd like to tell you about some of our efforts to support the care and outcomes of people who live with diabetes as well as complex complications, including advanced kidney disease and obesity. For people who live with diabetes who have developed end-stage kidney disease requiring kidney replacement therapies like dialysis, kidney transplantation is the gift of life. It can offer people better health, better quality of life, and a life free of dialysis, which requires 3 to 4 hour sessions 3 times a week to rid their body of waste and toxins. Unfortunately, obesity is a major barrier to kidney transplantation. We know that kidney transplant centers exclude patients with obesity from transplant lists due to a higher risk of perioperative events. And our students and others have shown that obesity unfortunately disproportionately impacts underserved groups, including people of lower socioeconomic status. We've also learned that there are very few real-world programs to assist with weight management in people with obesity and advanced kidney disease, and there are very few research programs that have been advanced in this space. Moreover, some of our newer drugs like GLP-1 receptor agonists and GLP-GIP combination drugs have not been well studied in people living with advanced and end-stage kidney disease. So what this means is that people who live with diabetes as well as its consequences who wish for transplant often need to wait longer to show sustained weight loss, or they risk never being transplanted. Our multidisciplinary team has been focused over the last couple of years to try to reduce the barrier of obesity to kidney transplantation. And alongside our patient partners and patients with a lived experience, we've grown and launched a new trial which is focused on this underserved group. And what we hope to answer through this trial is whether a patient-centered, individualized weight loss program can assist real-world patients living with high risk or advanced kidney disease, end-stage kidney disease, receiving dialysis, lose weight for kidney transplant. And our intervention is a co-created virtual weight management program that is led by a coach and consists of tailored diet, exercise, coaching, and behavioral modification, as well as maximally tolerated semaglutide to a dose of 2.0 milligrams that hasn't been studied yet in this population. The design of our trial is pragmatic, meaning that it's embedded in routine care, so there's no extra need for special follow-up appointments, special blood work for people who participate in our trial. Our primary outcome is the continuous measure of weight at 26 weeks across treatment arms, so in both our virtual weight management arm as well as usual care. And then as secondary outcomes, we'd like to focus on the proportion who are able to achieve weight loss of more than 5, 10, 15, and 20%. It's important for us to look at their diabetes control with our intervention, things like frailty and sarcopenia, which are becoming increasingly important in weight loss trials, cardiovascular outcomes, as well as adverse events like gastrointestinal events. And so the people that we're hoping to study are quite a broad group, so adults age 18 years and older who have obesity that's defined by body mass index. And this is the body mass index that tends to exclude people from transplant wait lists and folks who have a higher risk of kidney disease or end-stage kidney disease over the next 2 years, or those who are receiving dialysis. And we will exclude people who have a contraindication to a drug like semaglutide, those who have type 1 diabetes, those who are using more than 0.25 milligrams of semaglutide, those who don't have access to benefits, and those who cannot receive transplant due to a medical contraindication. In terms of recruitment for this trial, we are planning to try to keep things as simple as possible. And so what we're doing is recruiting out of kidney, endocrinology, obesity, and transplant clinics through care providers. And we also offer self-referral into our program. And all study tasks and visits are organized and monitored centrally, and that's via our Diabetes and Chronic Disease Research Unit at St. Joseph's Hospital. This is just a graphic of what we're offering through our virtual weight management program. And this program, again, has been co-created by our team of multidisciplinary scientists, investigators, as well as patients. And we've done this based on literature review, as well as qualitative interviews with patients who live with these diseases. And it will be delivered again by a trained coach virtually every month. Includes goal setting, dietary advice that helps people balance diabetes and kidney disease, advice around exercise and movement, and then monitoring of diabetes. So we anticipate that we will need almost 900 people to be able to participate in this trial in order to help us answer our study question. So before we do that, we need to test the waters. So we're currently advancing what's called a vanguard phase, where we hope to understand whether we can recruit people into our trial, if people will remain adherent to their assigned treatment over the 26 weeks of the study. We hope to also understand through qualitative interviews if participants do find our program acceptable and our study acceptable, and whether we will come across any safety events that will stop us from studying this intervention in a larger randomized controlled trial. I'm very happy to say that we've launched, and so we're recruiting people who are currently cared for at London Health Sciences Centre and St. Joseph's Healthcare in London. We have Toronto and Halifax that will be recruiting and are in the initial phases of trial launch. And if this trial proves feasible, we will seek funding to launch a trial across Canada. And our hope is that this will then lead to an improvement in health and healthcare and more equitable access to best quality care for underserved Canadians who live with complex chronic disease. With that, I'll end. And again, thank you so much for the opportunity to share our work. I'm thankful to our funders, including Diabetes Canada, and we have a very large team behind us, some of whom are shown here in this picture, and certainly could not conduct this work without them. Thank you so much again.
Hi, my name is Sasha Delorme. I'm from Regina, Saskatchewan, and I'm affected by diabetes, both myself personally with type 2, and my son Brayson, who's 13, has type 1 himself. So I actually think that our journey begins more on the side of my mother. So my mother was adopted through the 60 Scoop program. And with that, she was adopted into a Caucasian family who didn't have any kind of connection to the Indigenous communities. So my mom growing up didn't have any of that knowledge, traditional knowledge, or, even just the background of knowing that there's type 1 or any kind of diabetes in the family. So when my son's diagnosis came in 2014, it was quite a shock. My husband and I both don't have any knowledge or, any background knowledge of type 1 or type 2 for that matter. So it really just, it just rocked our world. It turned it upside down. It just became scary for us in the sense that we didn't have any supports at the time. We were quite young. So all that being said, I started off the advocating for type 1 diabetes with my son and our family. We really did a lot of that together. And it just kind of started off with diabetes events and how, we would help out with lemonade stands and planning Halloween parties for families with type 1 and to include, their family members. Because support is just such a huge part of managing diabetes. When you don't have it, it takes a toll on your mental health. And that being said, I really truly believe that the mental health aspect is what led me to my type 2 diagnosis. So I had grown up in a home with a lot of trauma. My stepfather was an alcoholic, and so with all these traumas that I grew up with, I just feel that it really added to, a lot, like me myself having a lot of stress and anxiety, and not eating properly. Especially when my son was diagnosed, it really kind of turned into, he's top of the list. He is the most important. We had to make sure that he wasn't hitting those scary lows, which happened quite often as we were learning diabetes along the way. So it really kind of opened up my world to diabetes and what goes on dealing with my son's diabetes. But then when I myself was diagnosed in 2020, it was COVID times. And my doctor actually assumed that I had type 1 myself, just because my son has it. I had asked, though, just in case, to send the information in my blood work to wherever it is that it goes in Canada. And those results came back 2 weeks later saying that I had type 2. So I had been, since that diagnosis date for 2 weeks managing my diabetes the same way that I actually managed my son's diabetes. And we were all sure that, it was type 1. So it just kind of made sense that the management was working quite well. And when the results came back, my doctor and I were just as shocked as the other one was, hearing that it's type 2. And with all that, he assumed that, because I know type 1 quite well, that I would just kind of learn or know type 2. So that's been a challenge in itself, especially at the beginning, trying to figure out, how do I manage my type 1 my type 2 without, the extra needles that I would normally give my son. It's exercise, and there's all these other factors that affect blood sugars, as a lot of people know, but a lot of people don't know that as well. So stress levels and things like that really have added to my own complications. I not only have the type 2 diabetes, but I've got other conditions as well that I have to manage. So I've had them for years, since my son. And like I said, he always came first and I was always put at the back burner. So I've just come through a lot of different difficult situations as a mother and a caregiver throughout the years, and sharing those experiences and those hard times really is what I'm passionate about, so that we can make those changes throughout the diabetes community. And so I started off with advocating with Diabetes Canada, and now I advocate and have gotten a position with CanScreen T1D, where I will be visiting different Indigenous cultures across Canada. Different Indigenous communities across Canada. And we will be asking them, and learning how to create a protocol for engaging in different communities. So it'll be more of, I guess, a template that we're working on that we can kind of tweak when we're visiting different communities, as there are so many differences between Indigenous communities. It's not just like a one size fits all. And what we plan to do is to go out and find out what their needs are, what their barriers are to healthcare and other issues as well. And, it's just nice that this is finally being put front and center, I feel like, in the research world. It's just such amazing work that's being done. And I not only am learning the diabetes research aspect of it all, but I'm also learning the Indigenous culture as I as I work with all these different people, and an elder actually in my group, an Indigenous elder, who brings me along and shares the Indigenous culture and teachings with me while I'm working with her. So it's really been eye-opening in not only, the scientific aspect, but in my own personal spiritual journey. I'm just learning so much. And for me, not having that background, it helps. It helps with, I guess, just so much overall when it comes to my own personal issues and background that, that I've come through. it just really helps with that aspect because I've always been missing that spirituality piece growing up and becoming an adult. So yeah, all this work that I'm doing, it really kind of is coming full circle. Not only am I helping the diabetes world, but the diabetes world is helping me as well in my own healing journey. And I'm just so fortunate to be a part of all this amazing work that Diabetes Canada does and all the other organizations as well. And I'm looking forward to, making a difference. So that's really where my passion lies, is helping other families not struggle as I did. Thank you.
Thank you so much for sharing your perspectives and your expertise in the research space for diabetes. So thank you, Dr. Key and Dr. Clemens. And Sasha, you wear so many hats in the diabetes community. I really appreciate you sharing with us your experience. As we start to go into questions, so for those in the audience, you can put questions in the chat or in the Q&A. If you've dialed in by phone, you can also email your questions to research@diabetes.ca, and I will keep an eye on that inbox. One of the first questions we have here was hoping that, I think this one's for you, Sasha, if you could please tell us a little bit about the expertise and the perspective that a patient partner or lived experience partner can bring or does bring to research projects, as well as the research enterprise at Diabetes Canada.
Sure. So for myself personally, I have worked on, I guess it would be rating or scoring diabetes reviews. So what that means is the researchers will send in their applications or their grant proposals for different ideas when it comes to diabetes research. And people like myself, called patient partners, will actually go through and look at those and rate it kind of based on the importance or the impact that we'll have in our lives, our daily lives. So it's really neat that we get to be a part of deciding which projects are funded in the future. Like when people are wondering, where does your money go when you're doing your fundraising efforts? That's where. So, or a part of it anyways. So that, and then another thing that we do as well is working with researchers and physicians on the projects themselves. So a big part of it is being a part from the very beginning when they are applying for this funding, all the way till the end, and the follow through at the very end. So we have input throughout the whole process, which is great because a lot of the times a researcher will start off with an idea, this is what we want to do, this is what we think it will do. And then the patient partners come in with their personal experience and expertise and say, well, hey, actually, this could lead to answering this question or this issue that we have. So we can not only help out in that process, but we can change it from being one idea to adding on ideas or totally changing it in general, right? So it's pretty interesting.
Thank you for that. And I can say from my perspective, overseeing the grants review process, the conversation changes when you present the review from someone with lived experience. And it's really important to have that voice to set the tone for why the research is important to be undertaken.
Rachel, can I add just a little bit there? I've been privileged to work with many patient partners, and it's been, I think, a really enriching experience for both ourselves and investigators and patients. We learn things from each other that we didn't know. I think I've become a better physician having had the chance to work with patient partners. And I had some patient partners involved in some interviews that we were doing called qualitative interviews, where we try to pick up themes about challenges and barriers in diabetes. And researchers, we have this one lens that we look at the data, and clinicians have this one lens, but then patients brought in all these new insights. It ends up being a really rewarding and fruitful experience. So really, really great that Diabetes Canada is continuing to support this.
Thank you. Thank you for that. It's been such a great growth in the field as we incorporate the lived experience voice more and more. We can look forward to continuing to grow that. I have a question here from somebody who experienced early stage kidney cancer and then was diagnosed with type 2 diabetes. And so they're wondering if there is a relationship or perhaps shared risk factors between kidney cancer and developing type 2 diabetes, and if we could speak to the risk of cancer related to type 2 diabetes.
I'll jump in and say that I don't know that there's a direct link between kidney cancer and diabetes. Sometimes some of the cancer or some of the treatments that we use for kidney cancer have been linked with diabetes, sometimes even interestingly, type 1 diabetes. I saw the rest of the comment there. Really interesting that you had some joint replacements and you've really been able to improve control. So congratulations. I wonder if some of that maybe is related to being able to use those joints again and getting active and things. So long story short, I don't know that there's a direct link, but really interesting experience.
Thank you for that. I have a question here about whether anyone on this panel has any tips for managing type 2 diabetes if they don't have access to a family doctor. So maybe some general advice for somebody living with type 2 diabetes.
I can speak on that. So a big part of my type 2, I know having the other person with type 1 diabetes in the household, my son, I just find that I hit a burnout stage quite often, and especially when it comes to my own management. So it's just really nice that my partner actually helps me out. When I'm too tired to get my needle ready at the end of the day or to get my other meds and stuff, he actually helps me out quite a bit with even just like setting out those meds and things and getting them ready for me. So that's one of those things. But also just letting like I know a lot of people are shy and scared when it comes to sharing their diagnosis, whether it's type 1 or type 2. And I would just say to not. And a good example of that is that I was just at a diabetes conference not long ago. And about 15 minutes before I was to get up and speak, about maybe 20 minutes, I realized that I was very low and it was in the moment. And, when you're traveling and you're so busy, you're not thinking about food and how often you should eat being a type 2. So that was my first experience that actually hit me quite hard in the moment. And because I was so low, I didn't know that I had a bunch of low treatments in my purse. So you can come totally prepared for those moments. But in that moment, I didn't think I had anything with me. So it actually came to one of my colleagues that actually saved the day, and she had stuff. So she knew what to look for and she knew that I was looking funny. So she'd asked what was going on. So, yeah, again, I would just really push to, tell your friends, tell your family, make sure they know so that you have that extra set of eyes when you're traveling or whatever, because you do actually act quite different when you've got low blood sugars.
That's such a great example of how looking for support to the people around you can be incredibly helpful. And I think I was at that conference, and it's a really great way to also make sure that we are aware and able to support each other. And I think I have a question here that's quite related, so I'll ask it now. But for somebody living with diabetes, it can really impact their mental health. And do you have any advice or even resources for people with diabetes who are looking for support in maintaining their mental health through the emotional challenges of diabetes?
Um, for me, it was just a matter of finding therapy. So I got a therapist and I worked through a lot of my old traumas that helped with stress management and just kind of how to deal with those moments where you're feeling, like you need that extra support. So coming up with those tools with a therapist was a big, huge help for me. And then also I would say to join these groups, join patient advocacy groups or become a member of, the Diabetes Canada advocacy programs and stuff that are out there, just because being around people with diabetes and actually being able to resonate with them helps in such a huge way. So I would definitely suggest to open up your circle and try to get out there and, experience the diabetes world.
Yeah, I think that's really important. I agree completely with what Sasha said, and I just, want to expand further and say that, I think mental health is also a big challenge with young adults with type 2 diabetes, especially those who are currently, struggling with their diagnosis. And I think it's really important for anyone with type 2 diabetes to be supported by, a team of care providers, not only their physician, but also dietitians, nurses, pharmacists, in some cases, psychologists, and, having that really circle of people around you to provide support, I think is really important in terms of self-management and stress management in the context of type 2 diabetes.
Yeah, maybe I'll just also add that I think it's really important to share if you are struggling. Please let us know. Sometimes we don't do a great job of asking, and so if you are, always look for help because we can do that. And if we can't do it, then we can find someone to help. So please do tell someone.
Thank, thank you so much for everyone for speaking to that question. I'm going to try and combine a few questions here. So apologies if this comes out a little muddled, but there's a few questions here asking about whether type 2 diabetes is hereditary, and then questions about whether race and sex or gender are controlled for in research within diabetes. I was hoping one of you can speak to that a little bit.
So with respect to race, sex, and gender, I would say that we've gotten a little bit better about trying to consider these really important factors in our research studies. We are behind. So when it comes to people who are included or who participate in research studies, we do know that there is a gap. So typically, studies include more men and more Caucasian people than people of other races. So it definitely remains an issue, but we are working quite hard to try to be able to change the narrative, change the conversation around that, and really try to bring in representative Canadians into our research studies. With respect to whether type 2 diabetes is hereditary, it is. It's not always a direct hereditary condition, so it's not that you necessarily will have a gene from your parent that would give you diabetes. It's not always the case. There's some really complex genetics there. So it could be related to body composition or other risk factors. So it's not quite straightforward, but yes, there is an association.
Yeah, and just along the point of sex and gender, race, and ethnicity, in the area of young onset type 2, we know that young women are especially at risk of young onset type 2, that the rates are much higher, and that there are different considerations in terms of pregnancy and childbearing that come into play in terms of the management decisions, and also in terms of the occurrence of type 2 diabetes in young adults differs greatly across people of different races and ethnicities. And so we're just beginning to understand why that might be. And I'm looking at some of the factors that might affect that. So, we do recognize the importance of those issues in our research, and it's very complex to try and tease out all of those factors.
Absolutely, it is. I have a question here for you, Dr. Key, specific to your research that you presented about if you could answer what cholesterol was being measured and were patients placed on statin lowering medication as soon as they were diagnosed? Also, were those patients started on insulin or blood sugaring lower medications on diagnosis?
Yeah, fantastic question. So those of you who were looking at the numbers on the scale might notice that the numbers may be different than what you're used to. Usually, what if you're going to your doctor and you're looking at cholesterol, typically they're looking at something called the LDL cholesterol, what we call the bad cholesterol, the low density lipoprotein cholesterol. That target usually is less than 2. And for people who have previous history of something like a heart attack or a stroke, that could be as low as 1.8. But there are some issues in terms of the measurement of the LDL cholesterol that it could be affected by other types of cholesterol, such as triglycerides, that might be less accurate. So there's another type of cholesterol that can be looked at, but is not as commonly used clinically. But that's called something called the non-HDL cholesterol, and the corresponding target is less than 2.6. And those are the numbers that I was presenting. But the idea is the same in terms of having a target. And so we just use that because it would be more accurate. Now, in terms of the treatment, so you're right that a lot of the patients that on average they would have been on some type of treatment. So these are the levels that we observe taking into so these are the levels that are achieved by people on whatever medication that they're on. So some people may be on medication, some people may not be, and these are just the average levels that we see. So, so some people might have achieved a very good level on medication. Some other people might have achieved very good level without medication. So, we just took the average of everybody, and that's the same goes with the blood sugars as well. Some people may be on treatment, some people may not be, but these are the average results that we see. And I think that's really, a good starting point because it's the level that you achieve that, then plays into the risk of complications, which is our topic for today. And so this is a mix of people who are on treatment and who are not on treatment. It's whatever they have achieved at that time.
Thank you. Thank you for that. I have a question here for Sasha. It's about CanScreen T1D. And this person you mentioned your research coordinator role with the organization and reaching out into Indigenous communities. But could you tell us more about what the screening program is?
Yeah, sure. So the screening program is actually something that has been started in other countries and they've already rolled it out. But what we're doing in Canada here is basically my position with CanScreen. So the overall project is to really screen the general population within Canada when it comes to type 1 diabetes. So it is for type 1, but it's just because normally when children come in with the symptoms of type 1, by that point they're coming in a really really bad uh, state, I guess, right? So, for an example, my son came in with blood sugars of 55 when he was first diagnosed because we didn't know the signs and symptoms. So, what they hope to achieve by randomly kind of screening everybody, children specifically, is to prevent that from happening. So, what they want to do is test children, maybe say at birth. And this is all kind of in the works. We have to come up with, like the way that it'll be done and the manner and the way that you engage with communities. But what we have to build is basically a protocol on how to safely engage different communities. My job specifically will be to engage Indigenous communities, just basically to see what their needs and barriers are for healthcare. So, with all that being said, when a child is screened for the type 1 gene, it's an autoimmune antibody, and when the first one comes up, what they plan to do is follow and screen for the foreseeable future until, say, a second gene pops up. And when that second gene pops up, they'll know for sure that that child or person will be diagnosed with type 1. So with all the research, they're hoping that they can either prolong the diagnosis of type 1 or maybe even stop it from coming altogether. So opening up that screening process does kind of open up the world to more possibilities, right, when it comes to management and prevention. So yeah, that's the main idea, is to basically check all the children in Canada to see if they've got this gene.
That's really exciting, and it's such a new area of research. You think about screening to delay the onset potentially of type 1 diabetes one day, but more importantly, more urgently, make sure that people, to help reduce where possible, people being diagnosed while in DKA, while
Yes.
and make it less not an emergency. So I think having the patient voice at that table is incredibly important. So thank you so much for sharing with us today about that role. I have a question here for I think anyone on the panel about you speak more to the role or like the benefit of using a continuous glucose monitor and an insulin pump and how that's changing diabetes management and reducing complications.
I could speak on this really quickly as my son is on both. So we've got the Dexcom G7 and the pump as well, Medtronic. So how that works together is, oh, it's just great. So when we had started, we were giving our son about 10 needles a day, and it got old real quick. So I'll just tell you quickly a real quick stat, because this is pretty interesting for us. We had checked our son's sugars and, like, done the needles, the insulin injections, obviously, for a month straight, but we counted it. And this was kind of right before leading up to getting the pump, because we wanted to know how many needles we were giving our son in 1 month. So by the time we did the whole count, we saved all the tips and all the little test strips and stuff. And so for the test strips, we had 123, which means 123 finger pokes. And then the needle tips, so injections of insulin, were 239 in 1 month. And he was about, I want to say, 8 years old when we did this. So just to get an idea, that's how many needles children go through for type 1 in a month. So that really was what made us decide to get a pump. And now it's the pump is changed every 3 days. So I mean, it's like having one injection every 3 days as opposed to 239 in a month. So that's kind of the greatness. That's why we love these two things working together. And I'll just say a quick thing about the Dexcom, which reads his sugars every 5 minutes. It's really great because we're able to have him at school and not have that concern while he's away from us. So we communicate with cell phones and are able to see his sugars, whether they're going up or whether they're going down, and we can help him by intervening. So yeah, I just wanted to add that quick personal bit.
That's amazing. I can imagine as a parent how reassuring it is to have that extra peace of mind. So that's fantastic. And I say, if and when we can get access for our patients for type 1 and for type 2, it really is a game changer. I think one of the biggest benefits is really to self-management. So the nice thing is that when you look at these technologies, you can see which way your blood sugar is trending. You can see what food does to your sugar, what exercise does, and it really allows you to anticipate where you're going and how to try to prevent what the next step might look like. So it can be a very powerful self-management tool. I also use it when I'm educating patients. So it's really nice to be able to look at that graph and see where trouble spots are and make that a really great conversation around how to help support. And in clinical trials and research, we know that in adults and children too, we can reduce the risk of low blood sugar, severe low blood sugar, and improve quality of life and lower blood sugar as well. So really great tools to have.
Thank you for that. And combining two questions here related to pre-diabetes. And what someone's asking about whether diet and exercise alone can stop pre-diabetes from developing into type 2 diabetes. And if related to that, whether CGM use is recommended for somebody with pre-diabetes.
Yeah, so we know we have really good evidence that people with pre-diabetes are able to modify their diet and do physical activity and reduce their chance of progressing to type 2 by about 30%. And in some cases, medication can be used on top of that. So it can work, although it's not 100% guaranteed. It depends from person to person. And I guess the second question was about CGM use in pre-diabetes. Yeah, I don't have a lot of experience with that particular. I suppose, I mean, just as it can help provide, insights in type 2, it can provide insights into pre-diabetes, but I imagine it would be hard in a practical sense to get financial coverage for devices at that stage, and it may be challenging in terms of insurance providers.
Thanks. I think following along on this line, we have a question here about whether insulin resistance is common in the community, whether, and you can speak to insulin resistance and diabetes.
So insulin resistance is definitely common and highly associated with diabetes as well as obesity. And when we think of the reasons why diabetes type 2 happens, is that our body has a lot of insulin and our tissues just have a harder time using it. So sometimes we can see our body compensating, and that despite us having insulin resistance, our sugars are maintained. Or you start to see the sugars impacted when the body kind of gets a little bit tired and can't manage that amount of insulin resistance. So you start to see the sugars go up. Then when we go up to a certain point, that's when the diagnosis of diabetes is made. So definitely common and underlies a lot of the conditions we're talking about today.
Thank you for that. And I have somebody here related to that to CGMs asking whether checking your glucose levels too often has ever been linked to raising glucose, and maybe you can just speak to, I think, the mental burden of regulating and constantly checking a CGM.
I can speak on the lived experience part of that. So when we first started my son's CGM, it was a whole new world. There are settings on there, and we had it, going off every, I don't know, half an hour or something like that. It takes a little while to tweak what you want the alarms to go off at, but I would definitely say it added a huge level of stress for us. Just because we were checking so often, and we really wanted to jump in and correct blood sugars as they were going up or as they were going down, because you're just seeing it in real time. So, we weren't thinking that, yeah, it's going up right now, but it could just drop really fast. So as a parent, it added a lot of stress to us specifically, not so much our son because we did all the management, but it did add that extra factor of stress for sure.
Thank you for that, Sasha. And I'm going to end by combining two questions I have here as our last question for the evening. And someone's asking about whether there's any specific indicators that might lead to a particular diabetes complication. And I think related to that, just if you have any advice for people who are concerned with developing complications resulting from their diabetes, they might want to share to end the evening.
Go ahead, Kelvin, were you gonna? Sorry.
Go ahead.
I didn't want to cut you off. I was going to say the fact that we're thinking about complications and thinking ahead is amazing. I think some of the folks that I treat that have a complication now reflect back and think, oh my goodness, I had no idea that this could be a possibility. So I think the fact that you're here and that you're thinking about it goes a really long way. I think as endocrinologists, we know that blood sugars are really linked with a lot of the complications that we're talking about. So make sure that you're doing the best you can with your own self-management and getting all the support you can from your physicians from a sugar standpoint. And I'll let the others comment as well if they'd like to.
Yeah, get your eyes checked, get your feet checked. It's important. Get your kidney checked. There's blood tests and urine tests, and follow up with your healthcare provider regularly. We routinely monitor and in some cases initiate medications also in order to prevent these complications. It's really important.
Thank you. Thank you so much for answering all of these questions. I was thrilled to see how many we were able to get through this evening. And so thank you to everyone who put questions into either the chat or the Q&A or emailed them. It was really great to be able to have this conversation with our panelists. And before we wrap up today's webinar, I want to extend our heartfelt thank you to all our supporters, our partners, and generous donors who've made today possible. To our partners and supporters, your collaboration and shared vision enables Diabetes Canada to move our vision forward and amplify our impact. And together we are working towards our vision of a world free of the effects of diabetes. And to our donors, your generosity has provided the vital resources we need to drive our mission forward. We're deeply grateful for your ongoing commitment and support. Your belief in our work inspires us to continue striving for a world free of the effects of diabetes. So thank you to everyone who joined tonight, and especially our panelists for sharing their expertise with us. We will be sending out a post-event email to all attendees with a link to this recording and an opportunity to stay informed and learn about future webinars. So thank you so much and have a good evening, everyone.